Thank you, everybody. Welcome, and thank you for joining us today. So we're kind of talking about how to do this evening, and I thought what we'll do is we'll start off and do presentations so you can kind of hear some of this, but I really want the evening to focus on more of a conversation both ways and some questions because I think a lot of things tend to come to mind as you're listening to this, and I'd like you to keep track of that, write down your questions. And then we'll have kind of a roundtable discussion, and I think the questions will serve as kind of a stimulus for the discussion. So let's see how it goes. But again, thank you all for being here. I think we're online as well on Zoom, and then we've got a great turnout here in person, so it's fantastic. This is kind of a treat for me because I've got basically my friends here. And so we get to just kind of have a conversation and talk about something that I may be biased, but I think gut health is the center of everything, and certainly nutrition, and it impacts our lives. So I'll start off with our first speaker, who's Dr. Jennifer Park. Dr. Park is board certified in family medicine, and she specifically focuses her expertise is on preventative and integrative care as well as women's health. She's native to California and born and raised in Los Angeles. She received her bachelor's degree in human development at UC San Diego, and then she went on to complete her medical degree at St. George's University. She completed her residency at St. Joseph's Hospital and Medical Center in Phoenix, Arizona. And she spends her time, other than patient care, at the beach, reading nonfiction. She does yoga, and she spends quality time with her husband and 2 sons, and speaking to the community about health. So without further ado, I'd like to invite Dr. Park.
Dr. Deen. Thank you for being here tonight. Before I begin, I wanted to acknowledge Mary Ford and the Miracle of Living Committee members for all of your efforts in planning these lecture events. Tonight's topic will cover gastrointestinal health. So in order to lay a foundation for the evening, I'll start by reviewing the anatomy of the digestive system. We'll go on to cover a couple digestive disorders and touch on the gut microbiome and strategies for improving gut health. 2,500 years ago, Hippocrates said, "All disease begins in the gut," intuitively understanding the pivotal role of the gut in overall health. The job of our digestive system is to turn the food that we eat into the nutrients and energy we need to survive. So the carbohydrates that we eat turn into monosaccharides, which are the building blocks, glucose, fructose, galactose. Proteins are broken down into amino acids. Fats are broken down into glycerol and fatty acids. Vitamins, minerals, and water are all extracted from our food. Digestion begins even before we put food into our mouth. Just the smell of food activates our salivary enzymes, and the mechanical act of chewing and the chemical breakdown of food starts in our mouth. The esophagus receives our food when you swallow. Let me see if I can. There's the esophagus, and it travels through past this lower esophageal sphincter into the stomach. The stomach produces more enzymes and acid to further break down the food, and it's brought down into the small intestine. This is a picture of the gallbladder and bile ducts. Pancreas releases more enzymes, and all of these enzymes are brought into the duodenum, or the first part of the small intestine, where further breakdown occurs. The majority of our Absorption of nutrients happens in the second and third part of the small intestine, the jejunum and ileum. And this is a cross-section of the small intestine showing these finger-like projections, these villi, which are responsible for increasing the surface area for optimal absorption of food, of nutrients. This is a further longitudinal section through the villus. And this pink layer here is a tight barrier. These are single cells that join together and they form this tight barrier that acts like a security system. And it decides what gets absorbed and what doesn't. You can see right below here, this is our blood capillary system. So all the nutrients are absorbed through this single layer here and gets into the blood so that it can be taken to the rest of our body for use. So the area of contact with the outside world, our GI mucosal surface area, is about 30 to 40 meters squared, which is the size of a badminton court. And it contains 80% of our body's immune cells, understandably. Once the contents of the small intestine goes through the small intestine, it gets released into the colon, and the colon is where water and electrolytes are absorbed. The colon also houses most of our gut microbiome, or gut bacteria, and one of the essential functions of the bacteria in the colon is responsible for breaking down soluble and insoluble fibers that couldn't be broken down in our small intestine. And these bacteria help break these down, and they form these compounds called short-chain fatty acids. One in particular, called butyrate, is essential to feed our cells in the gut and is essential for keeping a healthy gut. Bacteria also produce vitamin K and B vitamins, and once that is processed through the colon, it's all bundled up, waste is bundled up and passed through the rectum and anus. So as you can see, we have this amazing system that is very elaborate and intricate and involves several different organs. And if there's any dysfunction in any of this, of the organs during this process, we can have GI symptoms. So common GI diseases include GERD, or gastroesophageal reflux disease, IBS, irritable bowel syndrome, lactose intolerance, diverticulosis, diverticulitis, inflammatory bowel disease, Crohn's disease, celiac disease, and cancers. GERD is one of the most common GI complaints that I see as a primary care doctor. Symptoms can present as burning, squeezing, pain in the mid-chest, upper epigastric pain, a sour taste in the mouth, worse with lying down or after exertion. Other symptoms can include cough, laryngitis, clearing your throat, asthma. So as the food travels down the esophagus, it passes through this esophageal sphincter. And in a healthy stomach, the esophageal sphincter closes and allows the acid to remain in the stomach to further digest the food. There are lots of different things that can cause this esophageal sphincter to open or relax, causing this acid to come up. So different risk factors include foods that weaken the lower esophageal sphincter, and those include coffee, chocolate, fatty foods, whole milk, mint, smoking, alcohol, and different medications like NSAIDs can also loosen or weaken the lower esophageal sphincter. Increased abdominal pressure due to obesity or pregnancy, hiatal hernias are other risk factors. Complications can include esophagitis, which is inflammation of the lining of your esophagus, Chronic esophagitis can lead to ulcers, and scarring can lead to strictures. And when there's an intestinal metaplasia, that condition is called Barrett's esophagus, and that's a precancerous condition and can lead to adenocarcinoma. Other complications include laryngitis, cough, asthma. If the acid particles get into the lungs, it can cause pulmonary fibrosis when it's occurring for long periods of time. Pharyngitis, it can also cause recurrent otitis media. So the different diagnosis or ways to diagnose include a history and physical, esophagram, upper endoscopy, and esophageal pH test or manometry. So the first line of treatment for reflux typically can involve lifestyle changes. Eating smaller meals can help your stomach digest faster and doesn't stimulate your stomach to produce too much acid. Eating dinner earlier can also help because you'll stay upright for a longer period of time before laying down, and the gravity actually plays a role there. Sleeping on the left side can also help position the esophageal sphincter away from the acid from coming up. Reducing abdominal pressure, quit smoking, drinking, and over-the-counter medications can help. Different medications we also use, or you may be familiar with, include Mylanta, Tums. These are acid buffers, and they neutralize acid. There are H2 blockers that are over-the-counter as well, famotidine. Pepsid is its other trade name, and these drugs cause the stomach to make less acid. Proton pump inhibitors shut off the stomach's acid production, and they're very effective, and they can especially be helpful for patients who don't respond to H2 blockers and antacids. Motility drugs and mucosal protectors also can help with reflux symptoms. So moving further down the digestive system, we talked about the importance of villi. Celiac disease is a condition where the villi are affected. It's a systemic immune-mediated disorder, usually precipitated by exposure to dietary gluten found in wheat, rye, barley in genetically predisposed individuals. It can happen more in women than men. All races are affected, less common in certain groups. There are risk factors if there's a family history that it can increase risk by 10 to 15% if there's a first-degree relative. Type 1 diabetes, Hashimoto thyroidism, and other autoimmune diseases can also increase risk. Typical symptoms include diarrhea, steatorrhea, which is fat in the stool, weight loss, abdominal pain, bloating, poor appetite. They can also have signs of malabsorption, fatigue, iron deficiency, decreased bone mineral density. And typically this is diagnosed with serologic screening followed by a confirmatory biopsy. The treatment is lifelong gluten-free diet as the mainstay, and also to treat nutritional deficiencies. This is a diagram showing the villi that are changed by the inflammatory reaction from our body to the gluten. This is a little bit of a complex diagram, but I thought that it was important to kind of show that also between these cells that the single barrier of the villi, there's these tight junctions that kind of keep this security gate closed tightly, and different things can affect that system here, including the GI diseases, but also diabetes, food allergies, stress, alcohol, smoking, NSAIDs. So what is the gut microbiome? It's a big buzzword. We hear the importance of the gut microbiome a lot these days, and there's more and more research coming out. Bio means the distinct ecosystem characterized by its environment and its inhabitants. Our gut contains trillions of microscopic organisms, which include over 1,000 species of bacteria, viruses, fungi, and parasites. Different things influence what our gut microbiome looks like. It starts in utero with our maternal health, type of birth, whether somebody is delivered via vaginally or cesarean. Genetics plays a role, and then different things like stress, nutrition, exercise, and antibiotics also change our gut microbiome. So what is the importance of the gut microbiome? Well, as we discussed, the bacteria produce those short-chain fatty acids that keep our gut lining healthy. Bacteria also provide enzymes to make certain vitamins. They also are important for metabolizing bile in the intestines, so bile acids can be reabsorbed. Our gut is our largest immune system. It contains 80% of our body's immune cells. And bacteria also help produce hormones, including serotonin and other neurotransmitters like GABA. They also help produce estrogenic compounds, and they interact with endocrine cells in our gut. They secrete hormones that regulate aspects of our metabolism, blood sugar, hunger, satiety. The vagus nerve is the main nerve of our parasympathetic nervous system. This system controls specific body functions such as digestion, heart rate, and immune system. And it's responsible for the mechanical breakdown of solid foods, stimulation of the secretion of saliva. These functions are all involuntary, meaning you can't consciously control them, but so essential for the process of digestion. So to summarize, and to kind of summarize everything and to kind of give you takeaway points, what are some strategies to improve gut health? Well, all food is not created equal, unfortunately. Choosing nutritious foods can help you get the nutrients that you need. Colorful vegetables and fruits have different nutrients, so eating the rainbow, taking prebiotic and fermented foods contain good bacteria. Mindful eating, take time to chew, activate that, salivary enzymes to kind of start that process. Sugar, stress, and exercise help less sugar, stress and exercise. They change up the gut microbiome. So being mindful of that. And then stress also activates the sympathetic nervous system, which is the opposite, the yin to the yang of our nervous system. We need the parasympathetic nervous system to be activated to have that whole process happen. Avoiding unnecessary antibiotics and NSAIDs as well to help protect our gut microbiome, but also the gut lining. And optimizing sleep hygiene is key. Thank you.
Thank you, Dr. Park. Appreciate that. You guys want to hear a joke? You guys have all heard of Pop-Tarts, right? You guys like Pop-Tarts? Yeah. No. It's a trick question. The answer is no. Refined sugars. Anybody know why we don't have Mom Tarts? Good guess. Anybody? It's because of the pastryarchy. I love that one. Okay. I don't know if it's possible to go back to that first slide. If not, it doesn't matter. But I realized when I was sitting there, I was like, you know what? I didn't really introduce myself. I'm Dr. Omer Deen. My specialty is in clinical nutrition. I'm trained in digestive disease. I did my fellowship at Cleveland Clinic, and My real area of interest is, of course, in gut health and metabolism and digestion, but also obesity, bariatrics, preventative medicine and wellness and things like that. So kind of putting everything together to figure out how our lifestyles and our diet impact overall disease state. So maybe later, kind of towards the end, I'd like to leave room and time for questions, but after that, we can delve into that a little bit more if anybody's interested. Again, thank you, Dr. Park. Our next speaker is an old friend of mine, actually. We've been practicing together for a long time, Dr. Oren Zaidel. Dr. Zaidel went to UC Berkeley. We will not hold that against him. And then he went to medical school at USC Keck Medical Center. He did his residency at Cedars-Sinai, and then fellowship in gastroenterology and hepatology at UCLA. He has been involved in a lot of research. He's published research on intestinal motility, specifically on irritable bowel syndrome, which I'm sure you've all heard a lot about, especially more so recently. He's done work in the bacterial microbiome in animal and human intestinal tracts. And his specialized practice, he does a lot of irritable bowel syndrome, fecal transplant, which you might have heard of, as well as motility disorders. So it's an honor and a privilege to present Dr. Oren Zaidel. Thank you.
Thank you, everyone. Thank you, Dr. Deen. Sort of a high bar set, Dr. Park. That was a great overview on GI health. And Dr. Deen, a really high bar in terms of jokes to start. So let's try one. I have one GI joke. Does everybody know that they've actually found a genetic cause for diarrhea? Yeah, really. It runs in the genes. Thank you. I'll be performing at the Laugh Factory on Friday night. Thank you all. Thank you. Yeah, high bars indeed. So I really appreciate the opportunity to come and speak to you all tonight. I love very much Dr. Deen's idea and Dr. Park's as well, that we'll have an opportunity to talk and answer questions and really delve into gut health. I want to take a small detour into an important part of gut health, which is prevention of cancer. And so I'll talk a little bit about that, and then we can get into, I think, questions. And just as a start, let me ask the following question. If I gave you the following choice, 1, 2, or 3, what do you think colon cancer as a cause of death in the United States ranks as? 1, 2, or 3? I hear 3, I hear 2. I see it. You know what? You guys are super smart. You do not need me up here. It's 2. Second leading cause of cancer death in the United States. So for 2023, we're talking about 150,000 new diagnoses, of which about 50,000 people will pass away. So pretty big numbers. It's an important thing for us to consider. And for that reason, I want to remind us all of some of the colon cancer screening techniques we have, when to do them. We understand why they're important, such a large number, so we can't forget that in the scope of gut health overall. So who, what, and when? Well, you guys already know the who. It's all of you. It's all of us. That's the who should be thinking of colon cancer screening. We'll talk a little bit about the what and the when. You know the why. The numbers just define the why. So up until 2019, and we all sort of knew this number, one of the least fun 50th birthday gifts was a recommendation from your primary care physician to go get a colonoscopy. And so that was the number that was fixed in everybody's head for years. Turns out we've modified that number. Age at first screening for colon cancer should now be at 45. And just briefly, let me backtrack. We like to categorize people into average risk and high risk. We do a lot of categorization in medicine, right? It helps us just think of things in neat boxes. Now, we all recognize that's not how life works, but that's how we think about things. So I think it's always instructive for you guys to hear a little bit about how we conceive of things so you understand why we give the recommendations that we do. So average risk individuals and high risk individuals. First, let me talk about high risk. High risk, you can see here, anybody who's had, of course, a personal risk, has had a personal history of colon cancer or polyps, first-degree relatives, siblings, children, parents who have had colon cancer or polyps, and then, of course, symptoms. And these are the important things to remember while we're talking about gut health overall. Anytime there's blood in your stool, a significant change in bowel habits, shape, size, frequency, which persists, not just a one-off that lasts for a week or two, but something that persists. And, of course, pain, weight loss, or if your physician tells you that you have iron deficiency anemia. So any of those things, you're automatically in what we call the high-risk group. You should be talking to your primary care physician. You should talk to your gastroenterologist. That has a different set of criteria in terms of what and when we do things. But for tonight, I want to talk more about the average risk individual. So as I just said, we start at age 45 now, so that's a big change. So we should all remember that and remember to tell our neighbors and friends and family members that 45 is the first time of screening. And it's traditionally talked about as 75 is the end of screening for colon cancer. Listen, the truth is that's not a hard and fast cutoff. We're not really ageist, or we try not to be in this society. So that's when you stop colon cancer screening is a very individual conversation you have with your primary care physician, your gastroenterologist. So I know some people might not be happy with that, thinking, whoo-hoo, I got to 75, I'm cool, I don't need to talk about this anymore. Not so fast. We still need to talk about it, and that's, again, something that's very individual that you can get into with your healthcare provider. So you know the who. What's the what? Again, we like to categorize. There are one-step tests and two-step tests. And I'll talk about colonoscopy in a second. Just show of hands, interested. Who has had a colonoscopy in this room? That is the vast majority. Once again, winners across the board. You guys are awesome. And we don't really need to continue the conversation. We can talk about something else. Spring training opening tomorrow, first pitch, stuff like that. Excellent, that's awesome. So one-step test and two-step tests. Two-step tests, much like you would imagine, are tests that end with step 2, which is colonoscopy. So they're usually something less invasive, which, if it becomes positive, will result in the need to move forward with a colonoscopy. We'll talk about colonoscopy in a second. I want to talk about the 3 categories of two-step tests. Again, many of you might have experienced this. Stool-based testing, where we check your stool for microscopic amounts of blood and or certain types of DNA signs that there might be either polyps, which are growths in the lining of the colon, and or colon cancer. Imaging, so different ways of using radiographic imaging. I'm talking about CT scans, MRIs, X-rays, and then, of course, flexible sigmoidoscopy. I'll only touch on this. This is fallen out of favor somewhat. We can talk about the reasons in a second. Here are the pictures of those categories. So remember, colonoscopy is the one step. Why is it called the one-step test? Because colonoscopy allows us not just to visualize the colon and determine if there are any abnormalities. In this case, we're talking about polyps, but we can remove those polyps at the time of the procedure. Why is that important? Because it turns out that the vast majority of colon cancer starts first in a polyp, which are small little growths in the lining that originate from the lining of the colon. So if we remove those growths, the vast majority of the time we can prevent colon cancer from developing. Hence the one-step testing concept. You do your one test, you both diagnosed potentially and prevented the onset of something worse happening, in this case colon cancer. Some of the stool tests that you might have been exposed to already are fecal occult blood test, which is sort of exactly what it sounds like, which is a test where we use chemicals and we test the stool to look for microscopic amounts of blood. That microscopic blood, again, by definition, is microscopic, you might not see it, can be an indication of something worrisome going on in the colon, anything from polyps to early colon cancer. So it's important to know about it because early detection allows us to prevent. More advanced testing that we've had for probably the last 10 years now are fecal immunochemical tests, a little bit of a different technique, but it looks also for microscopic blood, which again can be and they're more sensitive tests than the older fecal occult blood tests. Still, both very valuable. Again, a mechanism for detecting microscopic amounts of blood as a precursor to something worse potentially happening. The most modern form of stool testing we have now are stool DNA testing. You've probably seen this advertised if you've even turned on the TV anytime in the last year. You've seen this advertised as Cologuard. That's the only FDA-approved DNA type testing that exists now. It's a stool test also, and it looks at two different things. One, microscopic blood, and two, DNA evidence of either polyps or colon cancer. So there's certain types of patterns of DNA that we tend to see more commonly in the context of polyps and colon cancer, and these tests can detect them in addition to microscopic blood. So it's sort of a stool test plus plus. Very easy to do. Oftentimes these kits are mailed home. You don't even have to go to the lab, give a little sample, seal it up, call a number, or drop it off at UPS. Couldn't get easier. So it's really expanded access to colon cancer screening for a lot of people, maybe not so much those of us in this room who have great community health, great community sort of health programs in hospitals, but those who don't can get access to this, and it's a really great part of that two-step process we described. CT colography, otherwise known as virtual colonoscopy, is a process by which you get a CT scan, which makes a two-dimensional image of your colon. What's neat is it's non-invasive in the sense that you're not undergoing an actual invasive test like with colonoscopy, which I'll talk about in a second. And so from that standpoint, it's somewhat safer. Not so neat, you still have to do a preparation. And if anybody, for those of you who've gone through the colonoscopy, we all remember the worst part is the preparation by far, not so much the procedure. You still have to do the preparation for the virtual colonoscopy. Also, you don't get the little benefit of having sedation, which we now do with almost all of our colonoscopies. Not so fun. And they insert some air in your backside during the virtual colonoscopy, so a little bit of discomfort. So some downsides, still, it being a non-invasive test is pretty appealing, and for some people, depending on other health risk factors, an appropriate colon cancer screening modality. Its limitations are it can't really detect polyps that are less than 1 centimeter in size, so these are pretty big polyps. So you're missing out on potentially smaller polyps that we can see via colonoscopy. Flexible sigmoidoscopy is a test that we used to do much more commonly in the office, doesn't require sedation, doesn't require an entire preparation. You use just an enema. You can sort of do it without too much pre-planning. No fun because you don't get sedation. And you're only looking at the first third of the colon. So alone, it is not an appropriate testing modality, but in conjunction with some of the stool-based tests can be a very valuable tool. Again, it's sort of, I would say in urban areas where we have great access to healthcare like here, it's fallen a little bit out of favor because there's just so many opportunities and providers that can actually do colonoscopy. More rural environments where there aren't providers who can perform the number of colonoscopies needed, it's a little bit more important. Less so for us. And then what about the when? So the fecal immunochemical testing, that's an annual test. And remember, these are the two-step tests. So what happens when one of these tests is positive, getting to that second step, means colonoscopy. If they're negative, you sort of dodged a bullet for a period of time. So annually with the fecal immunochemistry tests, the fecal occult blood, annually as well, the stool DNA or the Cologuard, every 3 years. Small note with respect to cutoffs in terms of age of Cologuard. Right now, insurance won't approve Cologuard after the age of 85, but I think that's an interesting point because you see there's already a differential between what standard recommendations are for ending colon cancer screening. It's not even 75. They're allowing Cologuard to be done in an older population. After 85, you can do it. Insurance won't necessarily pay for it. That's something you can sort of sort out with the company itself. And again, a conversation to have with your provider. The flexible sigmoidoscopy, again, not so important for our purposes here, but it's every 5 years along with annual stool, as long as your annual stool testing is negative. So you can't forget that part. And then 5 years for the CT colography or the virtual colonoscopy there too. Colonoscopy, in terms of timing, that's very variable. And so it's very dependent on what you found at your prior colonoscopy. For example, whether or not you found polyps, the size of polyps, the number of polyps, and what those polyps look like under the microscope. Certain polyps carry no malignant potential, so no potential to turn into colon cancer. And so that doesn't necessarily indicate a need to do a colonoscopy in under 5 to 10 years. Other polyps, which we technically consider precancerous, called adenomatous polyps, will require a more frequent follow-up, and that's the conversation you'll have with your healthcare provider, your primary care physician, and your gastroenterologist. That's why that's why I described that as variable. Otherwise, it's every 5 to 10 years if you're not in any of those high-risk categories, no personal history of colon cancer polyps, or any family members. Why the range, 5 to 10 years? The truth is we don't know the optimal time. There are certain institutions which will recommend once every 10. It's a conversation. That's something I encourage you to have that conversation with your healthcare provider as well. And so again, just to sort of summarize, while we're talking about overall gut health, it's always important to keep in mind that one of the big things which can derail all of our gut health is colon cancer. So keep that in the back of our mind. I encourage you to have these conversations with your primary care physician. Again, in the era of modern colonoscopy now, where we get wonderful sedation, it's not so bad. I'll leave it at that. I look forward to talking more about overall gut health. Thank you all for the opportunity to be here. I'm out of jokes. I'll leave that to Dr. Deen and turn it back over. Thank you.
All right. Thank you, Dr. Zaidel. Appreciate that. I don't know about you guys, but I'm having a colonoscopy on Monday, and I'm pretty excited. No, really. I am actually having it done on Monday. I'm kind of nervous. No, I'm kidding. I'll tell you what. Let's just do a quick pop quiz and just shout out answers. What's the universal gold standard for colon cancer prevention? What procedure is the gold standard? Colonoscopy, excellent. And what is the age where we're starting surveillance for colonoscopy now? 45, excellent. It used to be 50. And what's the hard cutoff of like the kind of the top end? That's a trick question, It is not a hard cutoff at 75. After all, you're not even old enough to run for president at 75. I will also be at the Laugh Factory this weekend. Okay, I'd like to introduce another friend of mine. Allan Rutenberg is a registered dietitian nutritionist. We have also worked together for a long time. He started at Torrance Memorial in 2003. He's been a registered dietitian for over 17 years, and he specializes in gastrointestinal disorders, cardiac disease, kidney disease, pulmonary, bariatric surgeries, and prediabetes. And he is especially a specialist in 80s music. So if you'd like some trivia, please welcome Allan Rutenberg.
Thank you, Dr. Deen. Let me just bring up mine. I will save the jokes for later.
Thank you.
Everybody happy to be out of the rain?
Yeah.
No. All right. Our gut is trying to tell us something. The question is, are we listening? Are you listening to your guts? Because it has a lot to say. What makes an unhealthy gut? Well, actually, this is a little reiteration of what the doctors were saying, but I didn't want to leave it out. I knew I wanted this presentation to be standalone in case it's ever given again without the nice doctors over there. So again, all these conditions, GERD, reflux, diverticulitis, losis, inflammatory bowel disease, which is, of course, ulcerative colitis and Crohn's, all these things can be related to your gut. And most people don't think about it. They don't realize the connection between our brains and our gut and all these other conditions. Even heart disease, as you just mentioned, colorectal cancer, even chronic kidney disease. All these things can be connected to how your gut and how healthy your gut is. Mood swings, increased cravings for sugar. Who has increased cravings for sugar? Raise your hand. All of us, sugarholics. My question to you is, who had the candies over there? We'll get to you in a minute. So, how do we tip the balance? Well, of course, we tip it with good bacteria. How do we get there? How do we do it? Well, first, let's talk about what gets you to an unhealthy gut. Poor diet, of course. So processed or junk foods, soda, candy, sweets, goodies, donuts, pies, all my favorite things. You'll be surprised to know Dr. Deen and I discuss donuts on a monthly basis. Don't tell anyone. Oh, did I say that aloud? So these are obviously things that you want to watch out for. Fried foods, also red meat, one of our favorite things to eat. Processed meat especially. But these things you really want to cut back on as best you can. You want to aim for more plant-based foods. When I'm talking processed meats, we're talking about bacon, sausage, luncheon meats, all these things. Those are especially bad for you for so many reasons, not just your gut health. But because of this presentation, because of my research, I am going to work a little harder on reducing my red meat, which is a hard one. Are you? He's not. He's shaking his head. Of course, he says. And of course, alcohol and excess caffeine. These things can all create an unhealthy gut. All right? So you want to minimize these things. But of course, everything in moderation. Those candies are fine if it's once in a while. The burger, the donut, you're going to have these things if these are things you love. I'm not taking these things away from you. I want you to enjoy yourself. But if you have candy today and you have a donut tomorrow and a burger and a fries the next day, you're not doing your gut or anything else much good. All right? So once in a while is fine, but you want to minimize these things as best as possible. So healthy gut, microbiome, as we like to say, the new fashionable term. How do we get there? Probiotics. Now, when I'm talking about probiotics, I'm not talking about supplements, because that's what you think of when you think of probiotics. You think of the supplements in the store that you're going to take. Those may not work as best you think they do, and they're not well regulated. As all the vitamins and other supplements on the market, they're not well regulated. They're not the same as the one next to it. They may not even work. There's a whole question about whether they get past your gut, even to where they, past your stomach and get to where they need to go. But probiotics help aid in digestion, metabolism. They support your immune function. They control these harmful microorganisms we're talking about, and even the production of vitamins, as was mentioned earlier, vitamin K and some B vitamins. So where do we get these probiotics that we eat? Fermented foods. It was mentioned earlier. I'm going to give you specific fermented foods to eat. Kimchi. When I was doing this presentation, in the middle of it, I was hungry, and I needed to eat something. And there's kimchi in my fridge because my wife loves it, a big jar of it. I made myself go eat some. Not that I don't like kimchi, but usually it's at the Korean restaurant. But I ate it right before I ate the pizza that I just reheated. But again, you can't be perfect all the time. But I did eat it because it made me think about it more. So there's lots more things. Who likes sauerkraut? Who likes a Reuben? My wife loves those too. I'm not a big fan of the sauerkraut, but if I see it on my plate, I might just have a little bit more, knowing that it's going to help. Yogurt. Yogurt is beneficial, but what's the problem with yogurt? I kind of gave it away in the slide. Too much sugar. Most yogurt is just loaded with sugar. So what you want to do is get one that's not necessarily plain, but just no added sugar. You can get the artificially sweetened, but that's not a good choice either. You're better off getting a yogurt that doesn't have any sugar other than what's come natural in the milk. Who gets non-fat yogurt? Why? Have you tried whole-fat yogurt? It's delicious. There's nothing wrong with it. Don't shy away from that. It's a little harder to find. But any of these things, you want to minimize the sugar that's added to them. And you want to make sure there's active cultures. That goes for kefir. Anybody drink kefir? Every one I've seen is loaded with sugar. I haven't tried one without sugar, but I'm going to try it next time because of this presentation. So these are things you want to look for. Tempeh. Anybody know tempeh? Soybean products, miso, all these things are fermented and can help you. Kombucha. I'm curious about this one. I've never had it. Anybody have kombucha? Who wants to tell me what it tastes like? Yucky. Is it all yucky? It's good? So, well, to each their own. I'm going to go try kombucha just because of this, because I want to get more probiotics, more fermented foods into my diet. Now, also aged cheese. Look at that. You can eat some cheese. I'm not talking the cheese on your nachos. I'm talking these cheeses, and there's a few others out there. Pickles. However, most pickles in the market are in vinegar, and the vinegar has killed the live active cultures in there. So you need to find, if you like pickles, you want to find, there's some out there that are not in vinegar. Okay, they'll advertise it as such, but they are out there. And what you didn't know, if maybe you did, all these things I'm talking about have live organisms in there. You're eating organisms. And guess what? They need to eat. Not just you, them. What do you feed them? What do you feed the probiotics you just ate? You feed them with prebiotics, fiber, fresh fruits, whole grains, nuts and seeds, all these things we've been telling you about for years in a healthy diet, right? We always say this, but everybody's looking for a magic pill, the grapefruit diet, the Atkins diet, whatever. This is the diet and will always be the diet. This is what you want, all right? So what fiber? Pretty much everything I mentioned, but there's specific things that can help you and feed the kimchi and other things that you're eating. So green bananas and cold boiled potatoes. Anybody had a cold boiled potato before? Yeah, you eat potato salad, you're having cold boiled potatoes. These are resistant starches. They change when they're cold. The green banana as opposed to the ripened banana. These things can help your gut. I don't like green bananas. I may force myself to eat one, but you got to eat it quick because it's going to be yellow in a day or two, and then it's banana bread, and we have a whole other issue with sugar in there. Onions, garlic, of course, all these other things. These are all great sources of fiber specifically to feed your gut. Whole grains, I mentioned nuts and seeds, beans and legumes, chicory root. Of course, increase your fiber slowly. If you're someone who eats 2 or 3 grams of fiber every day and you know who you are, you have white toast and coffee for breakfast, you have a fake salad for lunch, just iceberg, and then you get to dinner and who knows what you're getting, fast food. If you go from that to everything we just talked about, you're going to be a little bloated and have other issues. So take it slow. Don't go from 3 grams to 30 grams overnight, okay? Ramp it up slowly. Don't be the balloon. So what's the difference, prebiotic, probiotic? I kind of did that, but I'll be honest with you. Before doing this, I hear these words all the time, and they sound very similar. This is probably the best slide I can think of to really show you what it is. Fiber, prebiotics are fiber you eat, and they feed the organisms you eat, which are the probiotics. But they're all food. They're all stuff we eat, so they sound similar. And again, we all think of probiotics as supplements you take, but it's really, you want them in the food. That's the best way we get our nutrients. It always will be. Polyphenols. These can also help your gut. What are polyphenols? High antioxidant and anti-inflammatory plant compounds. It's pretty much everything I just mentioned, but especially things like berries, strawberries, blueberries, cherries, apples, beans, nuts, and a lot of the red purple fruits are especially high in the polyphenols, all right? But also green and black tea, and yes, coffee. I know there's coffee drinkers in here. I didn't want to even put it in there because people probably should drink more tea. I had tea over here before we started. Who loves their coffee in the morning? Don't feel so bad about it. Of course, unless you have GERD and there's caffeine in it, then you need to talk to the doctors, all right? So dark chocolate. Is there any dark chocolate on that plate? Yes, yes and no. Who says yes? Yes. Do you know how dark that chocolate is from C's? It's not very dark. That's why it's very sweet. If a chocolate's sweet, it's not very dark. You probably need something closer to 70 or 75% dark to be beneficial. I doubt that's over 40 or 45. Also, black olives. And of course, wine, specifically red wine. But don't be like, don't drink a gallon, don't drink a bottle. Go easy on the red wine, okay? I don't want anybody going and saying, hey, Allan said I could drink a whole bottle of red wine. That's not what I said. But a little bit can give you a lot of these polyphenols, not as much in white wine, okay? But it's because it's the red grape. More polyphenols. Spices, lots of spices. These are just some of them. Turmeric, cloves, cinnamon, all these things are very high in polyphenols, good for your gut. Don't shy away from them. Get that food that's from other countries. Fast food isn't going to have this stuff. You got to be a little more exotic. Get them into your cooking if you haven't already. Of course, what are other important factors? These were mentioned previously. I'm just kind of reiterating it. As you can tell, a lot of these things are overlapped. but we didn't communicate ahead of time, so we don't know what we're all saying. But stay hydrated. That's an important thing. As we get older especially, the mechanisms in our brain that tell us when we're thirsty fail. If you're telling yourself, if your brain tells you you're thirsty right now, you probably needed something to drink 2 or 3 hours ago. So don't wait till you're dehydrated. How do you know you're dehydrated? Thirsty. I just told you that fails that mechanism. You're behind if you're thirsty. What's the best way to tell you're thirsty or you're dehydrated? Say it again? Your pee. What color should it be? Clear to light yellow. If it's yellowish approaching orange, you're dehydrated. You're a little delirious, you're a little faint. Just stay hydrated. How much water do we need? What do they always say? 8 what? 8 glasses. So I love this question. How big is a glass?
8 ounces.
Really? So if I look up glass in the dictionary, it'll say 8 ounces? No, it won't. A glass can be a 4-ounce orange juice that costs you $7 at the deli. It can be a 16-ounce goblet of wine. There's no set size. So that's nonsense, 8 glasses. And what people don't tell you is everything you drink counts. Milk, juice, water, tea, coffee, even caffeinated drinks count. They're of course a diuretic and you'll pee them out sooner, but they do count. In an emergency, you will drink, you want to drink them. But they all count. Even the fruit you eat counts. Drink with your meals, drink between your meals. Try not to drink before bed, but stay hydrated. Look at the color of your urine, all right? Getting adequate regular sleep, of course, regular times, going to bed is the best thing. If you're going to bed at 10, then 12, and then you stay up all night, those are never good for your body. Reducing stress, easier said than done. If anybody knew what my day was when my PowerPoint wasn't working properly, we'll know what stress was. Anytime you can minimize that, and of course, exercise. Now, to summarize all the things, minimize your junk and processed foods. The less ingredients, the less they did to it, the better. Less added sugar. And the great thing on labels today is they have that added sugar. They didn't used to have that. So if you see, don't anybody tell you, oh, that fruit has sugar. Ridiculous. The milk has sugar. Ridiculous. Is it chocolate milk? Yeah, it has added sugar. That's what you want to watch out for. Minimize the caffeine and alcohol, a little red wine, assuming you don't have other issues. And watch the beef and pork intake, especially the processed. More fresh fruit, vegetables, nut seeds, legumes, spices. Spice it up, more fermented foods. This is probably the biggest for me. I'm going to be adding more fermented foods just because of this talk. And of course, stay hydrated, get moving as best you can within your abilities. Bottom line, trust your gut. Thank you.
Thank you, Allan. Appreciate that. All right, so takeaway from this, and thank you again for this, Allan, but the takeaway from this, I'm really gonna try to get more banana bread in my diet. I think that,
That's what you got out of it?
you know, I think I can do it. I think I can do it.
Bananas in the bread.
Right, right. Okay, so we are now at a point where this is kind of the exciting part for me, where I'm thinking, let's have a conversation and let's take questions and we'll kickstart that way. Obviously, anything on gut health, nutrition, but really we can take it anywhere you guys like. So we'll open it up. I think we've got some questions coming. In the meanwhile, no problem. So we'll kind of talk in the meanwhile.
Colon polyps. I've got diverticulosis. Do I have colon polyps, and how do those two relate to each other?
I'll repeat the question for those online. So the question was about colon polyps, and if I have diverticulosis, does that mean I automatically have colon polyps?
Great question. So colon polyps and diverticulosis can be confusing and seem very overlapping, two totally different things. Here's how you think of them. Diverticulosis, or diverticuli, are tiny little pockets in the lining of the colon, almost like little outpouchings. A polyp, on the other hand, is a growth that originates from the lining of the colon. Polyps we remove. Those are the things that are precursors to cancer, not diverticulosis. Just having diverticulosis does not increase your risk for colon cancer. The important point about diverticulosis is those little pockets can become inflamed. And when they become inflamed, it hurts. You have pain. It's like an infection. The pocket gets filled with stool, bacteria, sets up an inflammatory reaction in your body, does not feel good. Oftentimes it requires antibiotics to treat that. Sometimes just resting the gut, so not eating or drinking for a day or so, or just drinking, I should say not drinking, because then what, you're gonna have dark yellow pee? No good, we learned that from Allan. But just drinking, minimizing oral intake, right, regular food intake can quell a bout of diverticulitis, but you should always be mindful of remembering where you were told which part of your colon your diverticulosis was, because that helps you sort of keep an eye on where the pain might occur, and that's the time to contact your primary care physician, your gastroenterologist, and talk about, do you need to do antibiotics? But it's a great question, two totally separate things. Diverticulosis, no increased risk for cancer. Polyps, yes. Those are the things you got to watch out for.
We'll take this one up here.
I wanted to follow up on the diverticulitis. There used to be the doctors would say stay away from certain foods like nuts and seeds, and then all of a sudden they flipped the script and said, that's fine, it's okay, you can eat it now. Where do you stand on that?
That's a great question. We absolutely flipped the script. We did it just to make sure you guys were awake.
Dr. Zaidel, I just want to repeat the question for those online. So the question was that, not me, but other doctors seem to have flipped the script on nuts and seeds. We used to tell you to avoid them, and recently we've been saying you should be eating more nuts and seeds. And so we'd like Dr. Zaidel to weigh in on that.
Yeah, great question. We absolutely switched, and the reason we switched or flipped that script is it turns out that we've looked over the last now 30 years at the incidence of people that, so let's I'm gonna back up. Diverticulosis versus diverticulitis. Diverticulosis simply means that you have those pockets. When those pockets become inflamed, that's when we call it diverticulitis. Itis really, and you can use this you can impress all your doctors with this. Anytime they say something itis, it means inflammation of that something. So diverticulitis, so it's inflammation of those little pockets. And so what we discovered, and you're absolutely right, our thinking used to be that little pieces of the seeds and nuts, which we don't completely chew and go through the GI tract, get through the small intestine and into the colon, can get caught in those pockets and trigger a flare of diverticulitis. Guess what? We watched over the last 30 years, we looked at people and followed them prospectively and asked, is there any difference in the rate at which people develop diverticulitis between groups that ate seeds and nuts and groups that didn't? None at all. So we've backed off of that recommendation. You do not have to watch seeds and nuts, but there's one little asterisk there. If you as an individual know every time you eat X, it triggers some pain or something that is similar to a bout of diverticulitis you've had, that's what matters for you. And so I'll give you an example. I can give this recommendation and someone said to me, but every time I eat popcorn, the little bottom of the kernel, it doesn't get totally digested, gets into my colon, and it causes me upset. Do you know what I tell them? Then you don't eat that. The most important part of the story is what you've noticed yourself, but that comes with a lot of self-awareness, and not all of us have that. So as a rough rule, you're cool with the seeds and nuts. But as a specific thing, you have to know which things are triggers for you. And for some people, they still are. Great question, though.
Just one thing to add to that, because I get this all the time. Yeah, I can't tell you how many times patients have told me they can't eat nuts and seeds because they have diverticulosis, and I'm like, why? It's when you have a flare-up. When you have diverticulitis is when you want to avoid it. You don't want to aggravate your insides. But when you're feeling better and you're not inflamed, you want to eat these things. These things are beneficial. Don't shy away from them. And the only thing anyone ever told me that gave them an issue was popcorn. And it was one time. There's no evidence to suggest nuts and seeds do any of this, even popcorn. But again, like Dr. Zaidel said, if there's one thing that causes you a problem, then stop eating it. But don't shy away from those things because those are healthy, as we talked about earlier.
Thank you. Let me take a few questions here that we got on Zoom, but then we will come back. What about apple cider vinegar? Is that good for gut health?
That's you.
That's me. Okay.
That's your favorite thing.
So the thing I struggle with is how not to give an hour lecture on, apple cider vinegar is good for you. There are many benefits to it. Again, everyone's a little bit different. Apple cider vinegar has actually been good for glucose and insulin sensitivity. And it also actually helps counterintuitive with acid reflux. And so a lot of times you look at the cause of acid reflux, which varies. There's different causes, and the kind of blanket that we all think about is that acid reflux is related to my stomach's making too much acid. But that's actually not the majority cause. If your microbiome is off balance and the bacteria that ferment sugars and refined carbohydrates, which tend to get fed when you're on what I call the SAD diet, the standard American diet. Those bacteria produce a lot of gas. And so that gas then causes back pressure. Think of plumbing and pipes. And that back pressure is going to cause that acid to bubble up in your stomach. And so one of the things with apple cider vinegar is that it will alter your pH balance over time. This is not a quick fix, but over time, when you take it, say, every morning, it will alter your pH balance where you're going to start killing off some of those bacteria that usually thrive in that very acidic gas environment. So anyway, so there's that. So, and there's metabolic benefits. So it does stimulate your metabolism to some degree as well. We'll take another one from Zoom.
Dr. Deen, can I ask a follow-up to the apple cider vinegar thing?
Absolutely.
Amount.
Oh, so it's hard to really pinpoint an amount. So I take it myself, and I take 1,500 milligrams, and I take it in a capsule because I cannot stand, I don't know, God bless anybody who drinks this stuff. It smells and tastes like gym socks, in my opinion. I tried it, when back years ago, I was like, oh, I'm going to so I got raw, unfiltered apple cider vinegar, and I put it in a spoon and I went, oh, So I tried diluting it in water. That just prolonged the misery. So I get capsules on Amazon, where I get everything now, and I just drink it with a glass of water, and I'm done for the day. So the problem with gummies, so generally, yes, but the problem with gummies is what do they put in there? Sugar. And so generally, we should minimize sugar to as close to zero as we can possibly get and tolerate. Okay. So you're thinking, if I have acid reflux, why would I take something that's acidic, right? It's because what you're trying to do, you will downregulate your own intrinsic acid production when you're taking acid, when you're taking vinegar. That's why I said it takes time. So it's not something that's going to happen overnight. It's going to take weeks to months. So if you have acid reflux, you're generally going to see your physician. You'll probably be on a proton pump inhibitor to help in the short term. You can often take the apple cider vinegar along with it, and over time you're going to taper down and off your proton pump inhibitor, and hopefully you'll do all right with just the apple cider vinegar. And you can take it with food. You don't have to take it on an empty stomach.
Dr. Park used the term, or want to describe it, otitis media. What is that?
It's a middle ear infection. Middle ear infection. So as the acid comes up, it can just sinuses. So acid goes up. If it's very severe, it can go all the way up to the sinuses and also affect that whole system up in the face. And
The question was, what is otitis media? So that was in response to that. Okay, let me run through some of these here because they're piling up, which is fantastic. Any diet modifications for someone with kidney stones besides drinking more water and exercise? Banana bread. It's obvious.
Give me a minute. You got something for that?
Well, generally, so if you're having kidney stones, the big question is, and the nerdy question is, what type of kidney stones? There's calcium oxalate stones, there's pyruvate stones, there's multiple other types of stones. And I think it's important when you pass a kidney stone to have it collected and have it evaluated, to find out what the cause is, and that will tell you what you need to watch out for. One thing that I can kind of say as a blanket statement is that we would always tell patients as they get older to start taking calcium supplements for their bones, calcium and vitamin D. And my recommendation now is really nobody should be on calcium supplements. We generally have 7 to 8 times the calcium we need in our diets, even on the SAD diet. And so it's not that there's a calcium deficiency that's the problem, it's not being able to utilize that calcium. And so one factor that's tied into that, and I'll try to be quick about this, is osteocalcin, if you're familiar with it. The most numerous receptor on our bones is called osteocalcin. Osteocalcin's job is to reach out into the bloodstream, take calcium and bind it and mineralize it into bone, and that's what helps us to mineralize and strengthen bone. As we get older, osteocalcin is inactive unless it's activated. And so how do you activate it? And the answer is vitamin K2, which is different than vitamin K1. And so vitamin K2 will activate osteocalcin, and it will take calcium from the blood and mineralize bone. How do you get vitamin K2? Well, this is kind of what led me down this pathway and looking into all this. So if you look at, in the United States, as you get older, the risks of hip fractures and compression fractures in our spines is pretty high. But then you look at places like rural places in India or in Africa where people are in their 70s and 80s, and you don't actually see, I think there's an 11-fold increase in fractures in the United States than there is there. And you're thinking, well, we have an abundance of food and everything, which I think is actually the problem, because it turns out that the organ meats of grass-fed animals is an excellent source of vitamin K2, as are egg yolks and fermented foods that Allan just talked about. Well, we don't really eat fermented foods much, and we certainly don't eat organs. I mean, I told my mom, I said, you tried to get me to eat liver when I was a kid. I didn't like it then, and I certainly don't like it now. But in a lot of the poorer countries, they don't have access to meat the way we do. So when they do have access, they don't waste anything. And so they're eating liver, pancreas, spleen, kidney, heart, like they're eating these organs. So that's one idea. That's one reason that I think that they're getting it and we're not. So I generally most of us are vitamin D deficient. And vitamin D is kind of a marker for UV light. So I don't think it's specifically vitamin D, but I think it's a good marker. I tend to replace vitamin D3 and K2 together. Whole separate lecture on that, but anyway, so that's.
I did have one more thing.
Yes.
Even though I emphasize and encourage drinking tea, that can be an issue also for kidney stones. But they found that if you have citrus, specifically lemon in them, it can help avoid that, which is why I love my Arnold Palmers. Am I alone there? So put your tea with some lemon. That can help if you're a big tea drinker.
Mm-hmm. Okay. There seems to be an increased presence of colon cancer in young adults, way younger than the screening age, both anecdotally and research-wise. Do any of the speakers have insight? Start with Dr. Zaidel.
It's a great question. That is absolutely true. That's one of the drivers for the recommendations of our decreasing age at time of first screening now to 45 for colorectal cancer. The truth is we don't understand why. We're seeing it at an age group that is much younger than even the 45 group. It probably has a lot to do with what Allan and Dr. Deen are referring to, which is SAD, the standard American diet. There's environmental triggers undoubtedly related to this. We don't understand enough about why this is happening. All the more reason we have to be more mindful of any potential warning symptoms that can occur. And it's always an appropriate thing to talk to your healthcare provider about. It's a great question. We don't know why it's happening, but that it's happening, undoubtedly. I mean, I can tell you, there was a time 15, 20 years ago where I was not ever talking to somebody under the age of 50 about colon cancer that we discovered at the time of a screening colonoscopy. And sadly, now it's not nearly as uncommon as it was then. So there's no question we're seeing it. The why's a little bit more difficult to tease out. There's certainly an environmental component to this. I have to imagine that in large part that's diet mediated.
Thank you. We've had quite a few questions on yogurt, so I'm going to kind of pull these together and have a yogurt conversation. Number one, do all yogurts contain probiotics? Yes. What about yogurt if it's pasteurized? It really has no purpose, correct? No. Pasteurization does harm some of the immune globulins and some of the bacterial cultures, of course. But we were talking about this earlier, even one death from unpasteurized milk or yogurt is too many, in my opinion. So we kind of weigh the risks and benefits, and I would still go with the pasteurized.
Listeria is not your friend.
Listeria is not your friend. Is this working? Hello? Okay. So we were talking about this earlier where there were bacterial infections that were rampant from dairy. And so they started pasteurizing. And so although it kills off some of the bacterial cultures and probably some of the immune globulins also, or denatures them, I still think there's a net benefit to it. And I think, we're just living in a time where certain illnesses and diseases really we shouldn't have to worry about. So I would go with the pasteurized anyway. I think the bigger concern is the sugar. Sugar sweetened yogurt, whether it's artificial sweetener or actual sugar, is going to really feed some of those bacteria, the ones that we talked about that we don't want, that produce a lot of gas and fermentation in the process, and they kill off the good guys that we're trying to get after all. Yes?
Allan, I was wondering, there is a doctor out there that's been testing yogurt, and for the most part, most of them don't contain what they say they do, just like the supplements. Have you looked into that at all? Because it's like, if you're gonna go buy a yogurt, which one really has what they say is in there?
It is difficult to know what's in there. Yes, the food is better regulated than the supplements, like I mentioned earlier. You're never quite certain what you're getting, so get something different every single day. Don't rely on the same yogurt, and the only thing is for your live bacteria. That's why I mentioned all the other things. Eat all of them. Eventually, you're gonna get the good stuff. As far as which, I couldn't give anything specific, but you definitely wanted to say live cultures, and as Dr. Deen reiterated, no added sugar.
It's a very bad thing for consumers because they're told to go do this, and then you get the one that doesn't have a lot of added sugar to it, but you still can't be sure it's got the live, cultures in it or not. So one thing I found that I read about that has all the cultures is called Good Culture Cottage Cheese. And it's proven that it has the live cultures.
Yeah, I've heard of that.
Just to share.
So one question was, is there a brand of yogurt that you recommend? So
The one you like.
So I am the son of dairy farmers. So both sides of my mom and dad grew up on dairy farms, and they were actually neighboring dairy farms was how they met. And so I grew up in overalls. No, but so my mom to this day makes her own yogurt at home, and she insists on only using her own yogurt. So mom's brand. No, just look for the healthy organic yogurt. And I say organic, I know that term is overplayed, but the idea is that it's your best shot at getting milk and dairy products that are, you want your cows to be fed grass. And even at that, you want them to be fed grass that is not from ground that's been fertilized. You fertilize the heck out of the grass, and so you've got more quantity, but it's not nutrient dense. we do not want our cows to have grain and corn and soy and all these things that we're feeding them that makes them grow much bigger. Let's see, we had,
Dr. Deen?
yes,
Gentleman in the back was trying.
yes, please.
What is the best way to prepare for a colonoscopy so you don't have that mediocre prep? And actually, doctors I know, getting my colonoscopy, I had mediocre prep. And all the instructions are kind of good. So is there any treatment that might have, then you leave me out or 2 weeks out?
You know, it's such a great question because as you experienced, it's. Oh, sorry.
Repeat the question.
Sorry, I'll let Dr. Deen. So for our people.
So the question was, you know, what we call a poor prep, that, you know, you did everything you're supposed to do. You drank the prep, you prepared before your colonoscopy, and at the colonoscopy you were told by Dr. Zaidel, no doubt, that this was a poor prep. We weren't able to see what we needed to see. Try again and come back. And so the question is, what do I need to do to make sure that I have a good prep?
So it really is, the difficulty we have with describing these preps is, obviously we try to make a plan that fits most people, but it is not a one-size-fits-all process. So one of the, there you go. Excellent. So what we end up, a couple of tricks though that can be, so two things. Once you've been told that, then it becomes a very individual thing. So that's a conversation we will have before the next colonoscopy, or you'll have with your gastroenterologist before the next colonoscopy, in order to minimize that ever happening again. But a couple of tricks. So as you know, anyone who's been through it, you know the directions say that the day prior to the procedure, no solid food, right? Just liquids. So that's an important one. There's a lot of fudging on that one where people think, well, no meals, what does that really mean? Maybe I'll just have some scrambled eggs the morning before, they'll never know. Listen, the scope never lies. It sees all. So that's one thing. And in fact, if you can tolerate it, clear liquids for 2 days is great. It's tough for many people, right? Because they start to think, my goodness, what can I drink? Really, you're down to drinking for those 2 days. But remember, things that are rich in nutrients, like bone broth or broth of any sort, not just the Gatorade that you have to mix your Miralax up with, but any type of clear broth-like product, it can sustain you certainly for the 2 days. And really the important point there is not getting dehydrated. So 2 days would be ideal, but I'll tell you there's another trick. You know, again, you remember on the instructions for the colonoscopy, they talk about whether or not you're mixing up Miralax with Gatorade, or you're using that big bottle of Go Lightly, or even some of the newer preps, the small bottles of soup prep. They talk about mixing up 8 ounces and drinking it every 15 minutes for a relatively short period of time, 2 to 3 hours. Forget that. Start earlier and go more slowly. So it's not about how quickly you get the preparation in, it's about getting the entire volume in. It's hard oftentimes to get, imagine I'm telling you to drink 64 ounces in 2 hours, even if it's the most delicious beverage you can think of, you just get full. You get nauseated. Sometimes you vomit some of the preparation up. So again, we have these blanket recommendations to essentially provide the best results for the majority of people, but it's not, it doesn't work for everyone. One trick is always just to start earlier and go more slowly. 2 days is ideal of clear liquids. It really is. But I encourage you to have that. That's a conversation we should have as we get closer, because it's a really easy problem to solve. And it's true, you sometimes just don't know it's a problem until you get there and you realize, boy, this was an issue. And that has a lot to do with anatomy, that has a lot to do with everybody's individual metabolism. It's sometimes hard to predict up front. But once we know it once, we'll never allow it to happen again.
So I have a question here. Is stool DNA test offered at Torrance Memorial, and is it covered by Medicare? And Dr. Park, I'm wondering, in your practice, are you getting a lot of people asking for this option as opposed to being referred for a colonoscopy?
Yes, I mean, definitely for some patients, Hello. They prefer the Cologuard if they are a low-risk patient and they've had a previous colonoscopy, or for patients that, really, really don't want a colonoscopy for whatever reason. We'll have that discussion and consider a Cologuard for low-risk patients. The Cologuard is covered by Medicare, and it's a good option for patients that are risk. Low risk. It is a good option for patients that are low risk and prefer not to do a colonoscopy. The colonoscopy is still the gold standard, and I still do encourage everybody of screening age to consider the colonoscopy as the first line screening for colon cancer, though.
Thank you. Yeah, I agree. I'm a little harsher with my patients about it. I just say you should be getting a colonoscopy, and I'm like, why do you not want a colonoscopy? What's the matter? Why would you not do it? It's about your life. Huh? Yeah, that is true. Question, Michael.
What if, so you're mentioning that we transitioned from age 50 to age 45, and in public service announcements by Jamie Foxx, he says, go get your colonoscopy at age 45. But what do you do when you're doing your annual checkup and your primary care physician is still of the opinion that you don't need it till the age of 50? How do you, even though you tried, how do you have that conversation to convince him or her to incorporate the new standard?
Well, I generally recommend tasers in cases like that. It's the guidelines have officially changed, so it's 45. Now, one thing we didn't maybe touch on earlier, and Dr. Zaidel can elucidate, so the guidelines are actually starting at age 45 for the general population, and that's because we have seen younger and younger patients now coming in with colon cancer. And not to scare everyone, but it's actually very aggressive. We're seeing more and more aggressive colon cancers. But it's also 10 years before a relative who was diagnosed with colon cancer. So if you have a relative who was diagnosed with colon cancer at age 45, that means we would start you at 35. Dr. Zaidel?
Yeah, that's a great point, Dr. Deen, and it's a great question. So first, minus the taser idea, you just say,
come on,
I want a referral to a gastroenterologist. That's it. You don't need to go beyond that. You'll get the referral. Unequivocally, you should do that. In terms of the age at first diagnosis, it's exactly right what Dr. Deen said. It's 10 years younger than the age of diagnosis of a first-degree relative, or age 40, whichever is earlier. So if they were diagnosed at 60, you don't say, oh, well, I get to do it at 50. No, 40 then is your default if that age sort of parameter comes into play. And it's true, not just at a younger age, as we touched on, the colon cancer, that we're seeing colon cancer now. It's a much more aggressive form. So unequivocally, if you get that answer from your primary care physician, say, that's cool, I want a referral to a gastroenterologist.
How does the removal of the gallbladder affect digestive health? You want to do it, Oren?
Sure. I'll tell you some of the ways that we see. So the answer is a lot, but I'll tell you what we see commonly in the GI world. So so of course you can live a long, healthy life without a gallbladder. It's one of those organs where it has a function, but the body has this amazing plasticity or ability to pick up the functions that you once had, even though you're missing a particular organ. What we see, without getting into the nutritional aspects and the dietary aspects of things, I'll tell you what we see. So remember, the gallbladder stores bile. Bile is made in the liver. We're not removing your liver, we're just removing the storage vehicle for the bile. You remember the diagram that Dr. Park showed you. So what sometimes happens is, one of the things the gallbladder does is it squirts out that bile through that series of tubes common bile duct, into the small intestine in response to a meal, in particular helping us digest fats and proteins. And so what the body, you still make the bile, even though the gallbladder's gone. The problem is the liver doesn't quite pick up, in about 10% of people, pick up the slack in terms of when and how much bile to secrete in response to that meal. So sometimes it underdoes it, and the bile's not there to facilitate digestion. Sometimes it overdoes it. And so then, turns out that bile, we also call it bile acids, technically. Those bile acids can be super irritating to the colon. The colon sees too many of those bile acids, does not like them, starts to contract, diarrhea. So in about 10% of people, we see a post-cholecystectomy diarrhea. The good news is, in some subset of those people, that is mitigated over time, meaning it becomes less of an issue as the body sort of regains an ability to modulate how much bile is secreted. But even in the people in whom it doesn't get back to normal, we can treat it very safely and easily. There's something called a bile acid sequestrant, so something that binds up that bile, preventing the bile from irritating the colon. It's a medication, it's very commonly prescribed. It's called Questran or cholestyramine. It's one of the few, it's kind of neat, it's one of the few medications that when I tell someone you're going to need to go on it, I can tell them there's only one, this is one of the rare times you're going to hear that it has a side effect, one side effect, and it's a good side effect. What's the side effect? It lowers your cholesterol. So by the way, it's going to treat your diarrhea, and it's going to lower your cholesterol. You never get that, but the side effect is something awesome. So it does, of course it plays a major role in digestion, but the complications that we see anyway, this bile acid-induced malabsorption or diarrhea, very treatable.
Question for Allan. Can mild immunodeficiency be caused by an unhealthy gut?
I don't know, that's the best question for me.
They asked
honestly,
specifically for Allan.
Well, here's the honest answer. I don't know.
All
So,
We can all weigh in, but go ahead.
So I can weigh in a little bit. So that last picture, or the complicated picture I showed of the gut lining, it's a single gate of cells that pretty much prevents the outer world from the inner world. That gut lining also has protective mucus and bacteria that help protect that wall, but lots of different things can affect that wall. And so the thought is that lots of autoimmune diseases can be related to an unhealthy gut if that fortress is breached by different things like inflammatory bowel, diseases, or IBS, bad bacteria, bad foods, stress, smoking, NSAIDs. That barrier can be compromised, and if that barrier is compromised, there's stuff that shouldn't be coming into the body, which causes inflammation. And if there's inflammation destroying, more of the gut lining, there's just compromise, and all of that inflammation then goes into the bloodstream, which can then start affecting other things. So like for celiac disease, one of the dermatologic signs is a rash. And the relationship there is that inflammation, those inflammatory cells can then travel through the body and affect the skin. And so lots of different autoimmune diseases that we don't really know the cause of yet are kind of being linked to gut health, and lots of research is being done about that.
Thank you. And that actually is a great point you made, because I actually had a couple questions about that. Could eczema be caused by an unhealthy gut? The answer is yes. And do lectins impact your gut health? So the quick answer is yes. For most people, it doesn't cause a significant impact. So lectins, for those who don't know, are these proteins that specifically they bind to carbohydrates, but plants have them, and they're a protective mechanism for plants. And so eating raw fruits and vegetables, you get more lectins, and then generally if you cook them, then those are easier to digest. So like most things, some people are a little more sensitive than others to certain foods. You always hear somebody say, mushrooms give me gas, or this or that just kind of gives me a little gas or bloating. So there is a variation in our ability to metabolize and digest certain things like that. But as Dr. Park just pointed out, a big part of it is your gut health and the gut lining. You often hear the term leaky gut, right? And that's essentially what that is that barrier in that mucosa of your GI tract. As it is inflamed and it thins, those cells can sometimes separate. And so then things can sneak through into your bloodstream, and those things will behave as antigens and stimulate your immune system, right? Remember, the GI tract is about 85% of our immune system. So the process of eating and digestion stimulates your immune system, and that's both good and bad. So if there are antigens, then that's going to cause your immune system to react to those antigens. But also, in a lot of what we do, we try as much as possible when we're feeding patients to use the GI tract as opposed to going through the IV for that reason, that we want to stimulate the immune system and keep that active. All right. So we'll take a last question. I've got a lot of good questions here, but I know we're short on time. I am a 70-plus-year-old man. Why do I have constipation even though I eat lots of veggies daily, greater than 28 grams of fiber?
Are you just eating vegetables? Because vegetables have a lot of insoluble fiber. Think about putting twigs in your sink. What's going to happen? You need more soluble fiber. You need fruits. You need the insides of fruits, not so much the skin of fruit. You need pitted fruit, plums and prunes and apricots. This is what cherries. That's the kind of fruit you need. Not so much all these vegetables. Vegetables are great for you, but you want to get the fruit, you want to get fluids, and you want to keep moving like we mentioned. But specifically get those pitted fruits in your diet. Okay.
I think the hydration component is really important. So a lot of the patients, it's really difficult for some people to get in the appropriate amount of water. So water is important. Also, stress and stress management, giving yourself plenty of time to use the restroom is important. So again, for the colon to move, you have to kind of activate that parasympathetic nervous system. If you're in a rush or, kind of not giving your body a chance to activate that nervous system, the colon will just kind of hold tight. It's a motility thing where you have to activate the muscles in the colon to move and push the stool out.
I'll add one point to that. These are all excellent points. The colon is intrinsically a very weak-walled, weak-muscled organ. So a lot of the motility that we derive in our GI tract comes from us moving around, the movement of the body. So it's a really crucial point, not just the soluble fiber, and of course the hydration, and of course giving it time, but it's about moving, and that us as our entire bodies, all of which are crucial components. So it's really not just a one avenue sort of plan of attack. You really have to keep all of those things in mind: hydration, soluble plus insoluble fibers, time, and movement.
Thank you. So here's what I'm proposing. So we've got a bunch of questions here, great questions. I think we're running out of time as far as the official program and the Zoom. So what I'm thinking is, I'll tell you an interesting story because I like to tell stories, and then we'll wrap up the program. But and feel free if Dr. Park, Dr. Zaidel, Allan, if you guys have to leave. Otherwise, if you want to stick around, we can probably keep fielding questions and keep talking. So interesting story about that. Did you guys know that when you, when you have the sympathetic and parasympathetic nervous system, and when you have a sympathetic response, so if somebody jumps out from a bush and scares you, that's the sympathetic kind of, response where your heart's racing, right? But there's actually a very brief period of parasympathetic firing that supersedes that precedes that. So there's a parasympathetic fire, and then instantaneously right after that is a sympathetic system firing. And so back in the early days, you guys are going to love me for this. Back in the early days of movie theaters, they would play scary movies, and people were pooping their pants. And so when you think about scary movies that you watch now, there's kind of the music will kind of build up, and it kind of eases you into where something's about to happen. You're ready for it. So we tighten up our sphincters, and we know it's coming, right? True story, I'm telling you. That's the reason Hollywood added that whole that's the reason that they did that. So when somebody tells you, man, you scared the out of me, that's what they're getting at. Okay, on that note, thank you everybody for joining us. Thank you everybody online. We had something like 120 something people join us on Zoom, which is fantastic, and thank you all for being here. So we'll officially end the program, but we are here to answer questions and talk more. Thank you everybody. Oh, I'm sorry.